My name is Dr. Kenneth Iregbu. I'm a Chief Consultant Clinical Microbiologist with the National Hospital Abuja here in Nigeria. I also teach medical microbiology at the College of Health Sciences of the University of Abuja. In today's lecture, we shall be looking at fever of unknown origin, and we shall follow this outline: learning objective introduction, etiology of FUO, diagnostic approach to FUO, management of FUO, patient education, and of course, we'll conclude. Now, it is expected that at the end of this lecture, that the candidate should be able to define fever of unknown origin, briefly discuss the history and background of FUO, discuss the importance of FUO in clinical practice, discuss the etiology, and of course, the steps in the diagnosis and management of FUO. The first two people to describe FUO were Drs. Petersdorf and Bisson, and that was in 1961. And they defined it as a temperature of 101 degrees Fahrenheit, that's about 38.3 degrees Celsius, or higher, with a minimum duration of 3 weeks of illness without an established diagnosis, despite that the patient has spent 1 week in the hospital for the purpose of investigations. However, in 1991, Durack and Street proposed a revised definition, which divided cases of FUO into 4 distinct categories. And this was based on the emergence of HIV/AIDS and the use of immunomodulating drugs for treatment options. And so the 4 categories were the classic FUO, as described by Petersdorf, nosocomial FUO, which is found in patients who have been admitted in hospital, neutropenic FUO in patients who are neutropenic, and then HIV-related FUO in patients who are HIV infected. Now, at the moment, the usual 1-week inpatient investigation meant for the purpose of investigating them is no longer required. This is due to the advancement in technology that is now allowing sophisticated outpatient evaluations. Previously, patients could be admitted in the hospital for the sole purpose of carrying out some investigations, but today, most of those investigations could be carried out as outpatients because of advancement in technology and the sophistication of medical equipment in the present period. Now, usually we, like all clinicians who know, that most persistent fevers would have been diagnosed within 1 week of admission in hospital, or maybe 2 or 3 outpatient visits. Most fevers would have been diagnosed. However, the few cases that will not be diagnosed within this period are of serious concern because they could be masking some very serious conditions in the life of the patient. And majority of these FOUs in the industrialized world are usually non-infectious in origin, whereas in the developing world like Nigeria, they are mainly infectious. However, with increased travel all over the world within a very short time, it is possible to move infection from one part of the world to the other. And of course, the actual diagnosis as FUO would depend also on local exposures and the availability of current diagnostic facilities, because it is possible that one could diagnose FUO in one environment because of limitations of diagnostic facilities. And then when he goes to another environment, it doesn't qualify as FUO because they are richer in diagnostic capacities. So to a large extent, the etiology of FUO divided into 2 major categories: infectious categories and the non-infectious categories. And the actual causes vary from one region to the other based on exposures in the environment or availability of diagnostic methods like I did mention earlier on. And of course, the non-infectious or the inflammatory malignant cases are more prevalent in the industrialized world, and while infections predominate the developing societies. However, a systematic review conducted by Fosco et al. Some time ago actually showed that most cases of FUOs were due to infections, about 40% of them, while 20% were due to malignancies, that's neoplasia, inflammatory disorder, sorry, and then 11% by neoplasia and then other causes. Now, notwithstanding these developments, about 51% cases of FUOs will remain undiagnosed. This one does not depend on whether the facilities are there or not. No matter the level of sophistication, it has been established that about 51% will be undiagnosed at the end of the day. So looking at the etiology again, the infectious categories comprises bacterial infections, viral infections, fungal infections, parasitic infections. While the non-infectious categories will comprise autoimmune disease like the SLEs, the rheumatoid arthritis, and so on, malignancies such as lymphomas, drug-induced fevers, usually common among patients who are admitted in hospitals. And then you have others such as the connective tissue diseases, granulomatous diseases as the causes of non-infectious FUs. Now, among the infections, I mean, a litany of them, but these are just some of them. The list is not exhaustive. Pulmonary TB, extrapulmonary tuberculosis, enteric fevers, chronic sinusitis, cholecystitis, HIV infection, of course, Epstein-Barr virus, cytomegalovirus diseases, toxoplasmosis, coccidiomycosis, visceral leishman, and so many others responsible for FUOs. These are infections that we know commonly, but sometimes could cause FUO, that's why that we may not be able to diagnose them for some time. Then, among the non-inflammatory causes, the non-infectious group, that's the inflammatory and malignancies, you have adult skin disease, that's called a juvenile rheumatoid arthritis. We have SLE, systemic lupus erythematosus, which is a rheumatoid disease, periarthritis nodosa, rheumatoid arthritis, gout, sarcoidosis. These are mainly most of the non-infectious inflammatory disorders that may be responsible for FUO. Among the neoplastic group, have lymphoma, myeloproliferative disorders, acute myelogenous leukemias, multiple myelomas, metastatic cancers to the brain, to the liver, will all sometimes cause fever that we may not be able to diagnose within 3 weeks of investigations. Then you have a miscellaneous group, the cirrhosis of the liver, drug fever, thyroiditis, pulmonary emboli, hypothalamic syndrome. Then, of course, the factitious fever, which is not by any organic disorder. These are fever that the patient manipulates. Patient manipulate the body or take some drug that will bring up fever for one reason or maybe for gain or whatever. As we must be conscious of that too. Very common with young people. Then when you look at the 4 categories of FUO, in the bid to make a diagnosis, you should have at the back of your mind these 4 categories, because certain etiologic agents are associated with the different categories. For instance, the classic FUOs usually will be from patients who are coming from the community, usually community patients. And you have things like endocarditis, UTI, pretty complicated ones, abscesses, usually cryptic abscesses, tuberculosis, connective tissue disease, particularly in patients who are above 85, 65 years. And then, of course, for fevers in travelers, which, of course, may likely be infectious. Then if you are dealing with a neutropenic patients, of course, the most common challenging factor here is infection. So you have that, you have to bear that at the back of your mind. Then if you are dealing with a nosocomial patient who has been on admission in the hospital, then things like drug fever should be at the back of your mind. If the patient has undergone surgery, think of post-operative complications. If the patient is not ambulatory, think of venous thrombotic disorders, malignancies that are yet to be diagnosed. If the patient has received blood transfusion, think of transfusion-related reactions and so on. And if the patient has been on antibiotics for quite some time, of course, you can think of clostridium difficile infections. Then if you're dealing with an HIV patient or a patient whose social life, predisposes him or her to HIV infections, then think of HIV infection at the acute phase, which is where most of them will have fever. And then, of course, if you say non-HIV patients, then think of opportunistic infections in these patients like candida infections, think of pneumonias and things like that, that may be responsible for the fever. How do we approach the diagnosis of FUO? Now, with the approach to FUO diagnosis, FUO is not a disease entity. Please, I need to point that out. FUO is a symptomatic disorder, a symptom that the disorder is unknown at the time of the diagnosis. So how do we approach it? Just like we do in every normal patient. Clinical assessment, arrive at a differential diagnosis, we carry out investigations, and then we apply therapy. That also applies in the course of identifying the cause of FU. So the first major thing is a detailed history of the patient, clinical assessment based on history and physical examinations, and then we'll carry out some tests. Now, when you are through with that, you can now come back to say, okay, this patient is either having an infection or is unlikely to be an infection. So you must come to the conclusion or decision. It's either an infectious cause or a non-infectious cause of FU. And if you arrive at this point, you may decide to apply some empiric therapy and watch for the response. If you are thinking of an infectious cause, the most likely could be a bacterial infection, in which case you may want to apply antibiotic therapy. If you're thinking of a non-infectious cause, particularly the rheumatoid disorders or immunological disorders, you may want to apply a steroid therapy or any other form of therapy. Now, if at this stage the patient is not responding, then you may go down to the invasive diagnosis, invasive investigations. Initially, you do not get involved in invasive investigations. But when patient fails at this point, then you can now move over to invasive investigation where you can now do biopsy for histological examinations, you can do MRI, can do PET scan, and so on and so forth. Maybe at this time, perhaps, you may eventually arrive at the true cause of the FU and then apply a definitive therapy. So this is just the outline of a patient diagnosis of trying to get the etiology of the FU. So because the cause of FUO is very diverse, so there is no single definite approach to the diagnosis of FUO. What's important that you do a very thorough and diligent history taking, paying particular attention to symptoms that are most likely to point out to the cause of the FUO. For instance, the patient is dwelling on the history of weight loss. The history of weight loss may suggest that the patient probably has malignancy, possibly with TB, with HIV. The patient is given a history of rigors. That means that that patient most probably has an infectious etiology. Pay particular attention to past medical histories of trauma, of surgeries, or procedures that would have been carried out on this patient. Then family and social history is very, very essential because this can predispose patients to certain conditions that may go unnoticed for quite some time. Think of history of alcohol intake, smoking, contact with animals that can cause some zoonotic disorders, travel history. Where has this patient gone to? The patient probably who is not from a malaria endemic zone goes in there. He might contract malaria that may lead to FUO, which his environment back home may not be easily identifiable. Think of patients' drugs he's taken at home or self-medications. Occupational exposure. For instance, patients who work in the animal industry or a shepherd, something like that, might be contracting some infections that are not too commonly diagnosed, like brucellosis and things like that. Think of patients' sexual exposures or exposure to drugs, including hard drugs, recreational activities, look at his immunization records. All these ones will help you in coming up to a possible decision on what is responsible for the FU. And please, when you are taking this history, it's important that you pay particular attention to what the symptoms are pointing to. It's very, very important. And sometimes you may tie up 2 or 3 of them together and then get into one direction for the diagnosis. Risk factors such as surgical procedures, instrumentations, intravascular devices, immobilizations are all very helpful in determining the diagnostic testing necessary to obtain a diagnosis. And like I said earlier on, you may have to bring some of these symptoms together to find out what they are telling you, because these symptoms will be speaking to you that this is probably what is called, but unless you bring them together, you may not be able to pick up what the underlying condition is. Now, for instance, you have patients that are presenting with the B symptoms, which we normally describe as fever, drenching night sweats, and then loss of body weight, usually about 10% over a period of 6 months. So when you have these 3 together, you have fever, you have a drenching night sweat, you have a period of weight loss, it suggests very much to you that this patient probably has a malignancy, and usually of the lymphoma group. So you need to bring these symptoms together. The presence of rigors, like we say, suggests infection. If the patient is complaining about joint pains or swelling, and the case may be periodically, it may suggest to you that this patient is having a rheumatological disorder. So it's important that we bring these symptoms together. Then the next one is for you, because the key thing here in this patient is that he's having fever that we are not able to diagnose. with the preliminary investigation that with the normal way we do our diagnosis. So the key thing here is fever. And this fever you also use to monitor the response to treatment. And so you need to pay attention to this fever. What is the pattern of the fever? Sometimes the pattern of the fever will give you an inkling as to what this patient is really having on the ground, underneath the fever. For instance, you have a quatern or a tertian or a quatern fever, which may suggest that this patient probably has malaria. Tied up with the history or where he comes from, might point out to malaria. The patient is having an undulating fever, where you have fevers and sweats in the evening, and then by morning it is resolved. Now, this patient may be having brucellosis. And so if the patient is a shepherd or works in the animal industry and is having this type of fever, it may be pointing you to the fact that this patient probably has brucellosis. You have patients who have tick-borne relaxing fever, where you have fever that's there for a week-long fever, and then you have a remission for 1 week, and it comes up again like that. That is typical also, maybe borreliosis, or it's also typical of what you find in patients with Hodgkin's disease. The patient has double quotidian fever, in other words, has 2 spikes of fever every day. It may suggest that the patient has adult C disease. It could be malaria, it could be typhoid. So apart from picking other symptoms, the fever itself needs to be characterized as much as possible, because that may give you a clue as to what is responsible for the fever. Then after the history is the physical examination. Now, this physical examination is as important as the history in searching for the cause of the FU. And this physical examination needs to be guided by your history. Because when patient has laid emphasis or given information that suggests a particular organ system, then in your physical examination, you need to pay serious attention to that. If the patient is from the community and you have a new heart murmur, which may suggest bacterial endocarditis, the patient is complaining of spinal tenderness, or if you can elicit spinal tenderness in this patient, you might be pointing to vertebral osteomyelitis. Splenomegaly raises suspicion of biliary TB, Epstein-Barr virus, and cytomegalovirus, malaria, and so on and so forth. And may also suggest extrapulmonary tuberculosis. You have a patient that has relative bradycardia. That may suggest lymphoma and CNS malignancy. The patient has a sternal tenderness. It may be pointing out to myeloproliferative disorders. And when you have isolated hepatomegaly and FUO, it could indicate hepatoma or liver metastasis in the patient. Now, splenomegaly may also suggest Crohn's disease. It may suggest liver cirrhosis. You have patients with oral ulcers. Think of Becker's disease, systemic lupus erythematosus, lymphadenopathy, SLE also, rheumatoid arthritis, sarcoidosis. Then you have the typical rashes of sarcoidosis and SLE. These are all pointers to what may be responsible for the patient. Now, we must note that when a patient has hepatomegaly without splenomegaly, that almost always rules out rheumatologic disorder, because in most, if not all rheumatologic disorders, there are some elements of splenomegaly. So when splenomegaly is not there and you have hepatomegaly, then you may think of something else other than rheumatological disorders. Now, in most cases, like we said earlier on, the fever of unknown is a subtle or atypical presentation of a common disease rather than a new or a rare disease, as the case may be. What we always say is that fever of unknown origin is caused by diseases that are common, that are very familiar to us, but presenting in an atypical manner that is making it difficult for us to pick up the disease. So this knowledge, coupled with the history and physical findings, should guide you in the choice of laboratory tests you carry out for these patients. So in the course of carrying out the laboratory test, after your history and physical examination, you must take into this consideration that, look, we may be dealing with a very familiar disease that is presenting in an atypical manner. And so you have to be very rational in the selection of the laboratory tests. There is usually no universally agreed test to include at the initial stages of laboratory tests. The scope will depend on your facilities and what's available to you, the scope of tests you want to carry out. But that notwithstanding, we have a list of tests that usually should be part of the initial investigations: complete blood count and differentials, complete metabolic panel. You do analysis and culture. You do blood culture. You do a chest X-ray. You measure the creatinine phosphorus kinase, erythrocyte sedimentation rate, ESR, CRP. ANA, rheumatoid factors, and things like that. So you look at this list, you find that it includes tests that may help you classify these patients or group this patient to other infections or rheumatological disorders. And so these are some of the tests. You may add more. This is not exhaustive, depending on the facilities available and where you are functioning from. So you mean that at this stage of the investigations, it may give you a clearer view whether the FEO is infectious or non-infectious. So this will guide further direction, further investigation going forward. Now, at this point, when you have arrived after investigations, you may now decide to do a kind of diagnostic therapy, empiric therapy, and watch the response of the patient as part of diagnosis, not part of treatment this time around, as part of diagnosis. You want to know whether it's actually diagnostic or whether it is a rheumatological disorder or inflammatory. So you may try antibiotics, you may try steroids at this stage as part of diagnosis. Now, if that doesn't show you a clearer picture of what the problem is, you may now go further with further investigation, more invasive investigations such as the MRI, endoscopy, cholangiography, PET scan, and so on and so forth, depending on what's available to you. In some environments that are well-resourced, you have things like the BioFire platforms that can make a diagnosis of various infections just in one attempt. So if you have that, it helps a lot in the diagnosis or in the searching for the cause actually of FEO. Now, sometimes we notice that symptoms and signs of a particular disease do not all develop at the same time. So they come in, over a period of days. And because that is the situation in some diseases, it may be necessary for you to come back over again to look at this patient again, take a new history, and then thoroughly examine the patient again and probably order some other tests as the symptoms and signs develop over time. This is possible because today might be different from tomorrow. The symptoms and signs today might be different from that tomorrow. And as more of these things develop, you are likely to have a better clue as to what is really going on in the patient. So this might be necessary in some cases. Now, having come to this stage, the next thing is to look at the management. How do you manage these patients? The management empiric and the initial one that we did as empiric therapy and response assessment. Here we use antibiotics and steroids and some other treatment. That may just be what you need at that point, and then you continue along that line. Where that is not the issue, and you have ended up after further investigations to come to a specific diagnosis. And then if it is a viral infection, you may require an antiviral therapy. If it doesn't have any treatment, then of course, you may need to wait and treat, symptomatically while the disease take care of itself. You might require antifungal therapy if it's a fungal therapy. If it's a form of malignancy, it might require chemotherapy. If it's an immunological disorder or a kind of rheumatoid disorder, then of course, immunosuppressive therapy might be applied. Then of course, you can bring in some supportive therapies like antipyretics, reduce the fever. Usually require fluid and electrolyte management, you give them. If there's any problem with nutrition, you can give nutritional support, and then of course, manage any pain that's associated at that stage. Now, given that the variety of possible etiologies, there is usually no single treatment protocol for FEO that will suffice. So you treat according to what you have. It's important to investigate thoroughly and eliminate as many diseases as possible based on your investigations. Once that diagnosis has been made, then you apply a specific treatment. For instance, all it may require will be to stop a particular drug that is causing a drug-induced fever. If you have a negative blood culture from a patient suspected of having endocarditis, if the patient is neutropenic, rather than stopping antibiotics, you will continue. But otherwise, you may just wish to stop that antibiotic. You will need glucocorticoids empirically if you have a strong suspicion of specific rheumatologic disorders in that patient. Now, when the patient's condition is deteriorating, in other words, you have done everything possible, patient condition is not improving and is deteriorating instead, then at that place, you can go all out to do an empiric treatment all through. You apply both the antibiotics, the antimicrobials, you apply the steroids, and if your patient comes from an environment where tuberculosis is endemic, you might consider adding anti-tuberculosis treatment. Now, notice that all this while we've not been talking about surgical conditions. FUO patients rarely need surgical treatment, rarely. So it is not part of the major treatment plan when they're considering that of this. Now, the prognosis of patients with FUO will vary, depending on the etiology and the nature of the underlying disease. Usually, elderly patients and those diagnosed with malignancy will have poorer outcomes. Whereas those that are undiagnosed, ironically, the 51% that we said earlier on remain undiagnosed, even with the best of investigative instruments or facilities, will always do better than other groups. And children amongst them will always do better than adults. And most of them in this category, the fever will resolve spontaneously within a week, weeks to months, as the case may be. Now, if the patient is very stable and remains undiagnosed, rather than giving steroidal antibiotics and drugs, you give non-steroidal anti-inflammatory drugs, and some of them will do very well at the end of the day. Now, we realize that there's a lot of challenge in diagnosing or finding the cause for FUO. And this is important because patients need to be informed of the challenges that's associated with diagnosis of FUO, so that you can get their cooperation to work together with a view to arriving at the main cause of the FUO. So patients need to be well educated and informed of everything you want to do concerning the issue of trying to find out the cause for the FUO. So he or she needs to be educated to work and cooperate with the clinicians and the healthcare workers by giving them a good and detailed history. It may be painstaking, but the patient needs to understand that his or her cooperation is needed to be able to arrive at a diagnosis. Now, going by the diverse cause of FUO, it is also important that we involve people from other disciplines, such as the infectious disease physician, the rheumatologist, the hemato-oncologist. Need to get them involved early enough so that you can have an early diagnosis and institute appropriate treatment for the patient. Now, the key thing, like I said earlier on, in this patient is the fever. Fever is a key thing here, and fever is going to be used to monitor the response to treatment. Therefore, it's important that this temperature is well monitored and documented by the nurses. So the nurses need to know their critical role in the management of the patients with a fever of unknown origin. The pharmacist also is important because we notice that some of the conditions could be due to drug-induced fever. So the patient pharmacy need to know that, help you find out whether any of the drugs the patient is taking is able to cause drug-induced fever and perhaps find a solution or a replacement for that. So in conclusion, we say that over 200 diseases have been linked to FUO. And this poses a lot of challenges in identifying the cause of the fever. We say that FUO is not a disease entity of its own, but it's a manifestation of an undiagnosed disease condition, which most probably requires more diligent and well-directed approach to unravel. So a thorough and methodological history taking and physical examination will set the tone for eventual identification of the cause of the fever of unknown origin. And this may be repeated more than once before arriving at a diagnosis. Despite all these efforts, you will still find that 51% will remain undiagnosed. A basic well-directed laboratory test and imaging should be carried out as the initial stage of the investigation. Treatment, of course, is targeted at the cause, and prognosis will depend on the cause. Making early diagnosis, therefore, is very, very imperative in getting a good outcome for these patients. These are the references that you may consult later on. Thank you for your attention and for listening.